लोगों का एक मौलिक अधिकार होना चाहिए। पिछले 1 साल में जबकि पूरा विश्व एक इस महामारी कोविड-19 की महामारी को झेल रहा है, ये बात बहुत पुरज़ोर तौर से हमारे सामने आती है और इस कोविड-19 महामारी के दौरान हमने देखा है कि सामाजिक भेदभाव और आर्थिक असमानताएँ बहुत प्रखर रूप से हम सबके सामने आई हैं। इसी मुद्दे को के ऊपर हम डिटेल में चर्चा करने के लिए आज इकट्ठा हुए हैं। लेकिन ये जो पिछला साल रहा है जन स्वास्थ्य अभियान के लिए भी काफ़ी दिक्कतों से भरा रहा है और इन चुनौतियों के बीच जन स्वास्थ्य अभियान ने एक शख्स जिसकी कमी बहुत महसूस की है, वो है कॉमरेड अमित सेनगुप्ता, जो हर ऐसे मरहले पे डटे रहते थे और गाइडेंस देते थे। चाहे वो 1980 के दशक का भोपाल गैस त्रासदी रही हो या फिर 2000 दशक की के लिए में जो पेटेंट्स के खिलाफ आवाज बुलंद करने में काम रहा हो, उन्होंने हर ऐसे मरहले पे आगे आके शिद्दत से काम किया है। इससे पहले कि हम अपने आज के पैनल डिस्कशन की तरफ रुख करें, मैं गुजारिश करूंगी कॉमरेड गार्गे से कि वो एक जो कॉमरेड अमित की याद में हम लोगों ने एक वीडियो बनाया था, उसको सबसे साझा करें। और आज के इस मायूस दौर में जब चारों तरफ मायूसी है और की बहुत वजह हैं, कॉमरेड अमित सेनगुप्ता का एक वाक्य बहुत शिद्दत से याद आता है। वो कहा करते थे, कंसिडर ऑप्टिमिज्म एज अ पर्पसफुल एक्ट ऑफ पॉलिटिकल रेजिस्टेंस। उम्मीद रखना राजनीतिक प्रतिरोध का एक बहुत मानीखेज तरीका है। तो उनके इन्हीं शब्दों के साथ मैं गुजारिश करूंगी कॉमरेड गार्गे को कि वो हमारे साथ एक वीडियो साझा करें। कॉमरेड गार्गे।
A lot of people say that when a time for an idea has come, then there will be a large number of people who will start identifying with that idea. The world where fellow human beings do not exploit other human beings, that is a world without exploitation. In a new world that we seek to create, that world would also need to have a way of creating knowledge, of transmitting knowledge, of reaching knowledge out to those who need it the most. If we share knowledge, it does not diminish, it expands.
In the last 18 years, inequity has grown. You've heard that before. So we have 8 people. Some of these statistics are so startling, we just read them and go on. So I want you to close your eyes, think about this. 8 people, just 8 people have more money, have more wealth than half the human race. So you have, in the last 18 years, we have also learned that finally the hunger of capital has crossed borders into the belly of the beast. The hunger of capital today haunts Europe, today haunts North America as well, and not just our countries in the south.
The pursuit of the grey is elegant, but unfortunately, in some situations, it is a binary. And it is a binary when people die. When in the pursuit of the grey rather than the white or the black, when people die, I think it becomes a binary. And that is what we are seeing today. We are seeing that the rise of the private sector means that too many people are dying when they should not be dying. I don't think this is a situation when we can look for the shades of grey. We have to look for black and white.
So one of my best memories of Savar in 2000 was sitting with our Palestinian comrades. And for me, who in much of my student activism, we would march for Palestine. But we hadn't actually seen too many people from Palestine. It was one of the memories that we took back from Palestine. In these last 18 years, Palestine has shrunk further. And we have a world which is blind to what is happening in Palestine today.
Somehow, growing up in the 70s and 80s in public health activism, we always believed that health is about caring.
The struggle for health is a struggle for a more caring world. And I think that's what we are here together, to build a more caring world.
The days when you can make a difference through dialogue is increasingly getting over. Increasingly, countries in the north as well in the south are under the neoliberal discourse, the global neoliberal regime, under the influence of global capital. And so what matters, finally, is the number of people that we can today put on the streets, the number of people that we can mobilize.
I'll end by the immortal words penned by Bertolt Brecht when he said, "Will there be singing in the times of darkness? Yes, there will be singing of the times of darkness."
His ideas will not die. And with this, red salute to Comrade Amit. And with this, I hand it over to our moderator, Abhishek Royal. Abhishek.
A very good morning to everyone here. This was a very goosebump giving video. We will all miss him and we are always inspired by him. So today we are gonna keep this session in as bilingual both in English and Hindi. There's only one rule for the this session. It's if you have any question, please drop your question in the chat box and we can take it from there. मैं दो वाक्यों से इस डिस्कशन को स्टार्ट करना चाहूँगा. या सो मैं दो वाक्यों से इस डिस्कशन को स्टार्ट करना चाहूँगा. तो मैंने अपने पड़ोस में रहने वाले मैनुअल्स के वेंजर से पूछा जुलाई में कि आज भी आप मतलब टैंक खोलने क्यों जा रहे हो, आपको डर नहीं लगता कोविड से. तो उन्होंने मेरे से ये बोला कि कोरोना हमारे लिए नहीं है. दैट मीन्स दैट कोविड इज़ नॉट फॉर अस. इट्स लाइक जाएंगे 50 रुपये कमा के आएंगे, घर में चूल्हा जलेगा. And the second example that I wanted to give is not from the COVID times. It was, I have seen this thing during my college days. When I went to a mortuary, the person who was actually doing the actual autopsy was a Dalit. So he just took 2 shots of some alcohol और उसने पूरा dead body का autopsy कर दिया. And the doctor came after that and he just showed him the organs. He noted down all the findings and he just left within 5 minutes. All the cleaning, everything was done by that Dalit person जो कि वहाँ पे शायद 25 रुपये per day पे काम कर रहा था. So taking from these two incidents, and there are many millions of incidents that we all have to share, I wanted to start this discussion today. So we are talking about caste today. Caste system is the system that actually distinguishes our country from the rest of the other societies across the world. From centuries, caste and occupations are linked interlinked very seriously. The most labor intensive, least paid, degrading, and I would say hazardous occupations are the one actually done by these people coming from the belonging to the lower caste and lower economic sections, socioeconomic sections of the society. And this whole caste hierarchy in the social systems has actually been reported as the main one of the main reasons for this significant differences in the poverty, health parameters, and quality of life between the people coming from scheduled caste and other general population. हम लोगों ने पहले भी देखा हुआ है जब भी आउटब्रेक्स होते हैं या फिर एपिडेमिक्स होते हैं उस टाइम पे भी जो ये जो तबका होता है वो सबसे ज़्यादा अफेक्टेड होता है हर तरह से फाइनेंशियली हेल्थ वाइज डेथ्स वाइज सारे इंडिकेटर्स चरमरा जाते हैं लेकिन फिर भी उन्हें ज़्यादा फ़र्क नहीं पड़ता क्योंकि दे आर यूज टू दैट आइडिया कि दे आर लिविंग लाइक दैट एंड दे विल बी लिविंग लाइक दैट सो द होल आइडिया कि उनकी पहुंच ही वहीं तक है तो which actually makes us feel sad, makes me feel sad. COVID-19 has resulted in disruption of the economies across the globe. And these weaker sections of the society actually are taking the severe blow. They are mostly doing those jobs which are unsecured, least paid, and most of the all of us know that most of us have this privilege of working from home, but they don't neither have that privilege, nor they have the secured jobs, nor any secured source of income. So फिर भी वो काम करते हैं जो कि मतलब उन्हें लगता है कि शायद इस टाइम भी हो सकता है. Adding to this, those people who are working in the sanitary fields, they are pushed towards front lines without any personal protective equipments, very minimum help, on the same salaries or just an increment of few pennies, and they are working in those fields and still they are earning it, and they don't care about it because it is the way their lives have been. So today, in the memory of Dr. Amit Sengupta, this online panel discussion actually intends to explore the impact of this pandemic in the caste hierarchy and their occupations in India. The discussion also intends to dive into the social, economic, health, political, and human rights aspects of this association of caste and occupation in COVID-19 times. So, as a panel, I would like to invite first Dr. Sylvia to share her thoughts. Dr. Sylvia is a public health doctor and researcher. She is an MD in community medicine and has worked in both India and the UK NHS. She has primarily worked on the social determinants of health, such as caste, gender, livelihood, nutrition, education, etc., with a focus on the urban marginalized communities. I would like to invite Dr. Sylvia. Dr. Sylvia, over to you. You have 15 minutes, please, to share your thoughts on the topic.
Hi, can you hear me?
Yes, Dr. Sylvia, please go ahead.
Okay, so thank you so much for inviting me to be on this panel. And it was also important because it helped me also to think through things and kind of try to understand things from the context of this topic. And before I start the session, I want to share an analogy with the group. Um, so let us think of a field. Okay, there's a large field and it has some shrubs in it, and there is this tractor. So this tractor comes along and it starts clearing these shrubs. And as the shrubs are getting cleared, there is a rabbit, and that rabbit comes and it gets stuck under the wheel of the tractor and it starts screaming. So the people in the tractor, the person in the tractor looks out and he sees the rabbit screaming, and then people come running to see what's happening. And then there is a lot of discussion on the situation of the rabbit. There's a lot of sympathy, there's a lot of concern, and people are saying that, this is not correct. So the focus in this situation is on the rabbit. And in this with this analogy, I think this discussion is something that I would like to frame this discussion around. The rabbit is actually the outcome of a larger process. It's an outcome of a larger structural process or larger systemic process. But if you look at this seminar, what we're talking about is, if we look at the rabbit as representative or symbolic of people who are affected by a system or a structure. So it is people in this context who are doing what we call unclean occupations. And we know that a majority of those people are Dalits. And the unclean occupations in the context of, say, the healthcare system is, people who are dealing with animal or human bodies or carcasses. We have people who are dealing with animal or human waste or unsegregated waste. People, and this would include, like what you said earlier, people who are working in mortuaries, people who are working as cleaners, people who are working as housekeeping staff, the people who are cleaning the streets, and people who are collecting the garbage, people who are disposing the garbage. And we look at them as though something is happening to them, and as though we are outsiders who are viewing something that is happening to a group of people. And then we use things like, we say they need PPE kits, they need better salaries, they need better wages, they need dignity, they need rights. And if they die or if they get injured, we demand for compensation. And we say, this group is a very vulnerable group. But what happens is we stop there, and we see, when we think of caste and occupation, we only think of manual scavenging, we only think of unclean occupations. But what we have to really think about is, caste is not, it's not a passive thing. There is, I think, a need to move from the discourse of caste to the understanding of casteism, and the idea that caste is present across occupations. It's Caste is not an issue of manual scavenging. Caste is not an issue of unclean occupations. Caste is present and prevalent across occupations, and all those occupations are what are the systemic process of creating an outcome like manual scavenging or unclean occupations. So if you look at the tractor in that analogy, and if you look at it as representative of the healthcare system, then it's important, like JSA Delhi is going to look at, how they can take forward actionable plans in terms of addressing this issue. It's also important to look at what are the structures that are operating to create this system. So if we look at the healthcare system itself, and if we look at how, especially during the pandemic, so for example, if you take people who are part of the system, so for the very obvious example is doctors. If you take doctors and if you take cleaning staff, and the thing is, they are both frontline workers, they are both people who are exposed to high risk, because they are either dealing with directly with people who are highly infectious, that is COVID positive patients, or they're dealing with the products, or the contaminated, whether it's the waste, the contaminated waste, they are dealing with that in close contact. And as we know, the COVID virus survives anywhere between 8 to 7 hours. So it's not just the patient, it's also the products that come which are contaminated with the patient's droplets. Now, the if you look at the two extremes, if you look at the doctor and if you look at the say a sanitation worker or a cleaner in the hospital, look at the kind of discrimination that there exists. So it's not only the cleaners issue in isolation, there is a disparity between two groups of people within the healthcare system. And this can translate into a variety of things. How does media cover these two groups? How do deaths of these two groups get the reaction to the deaths of these two groups? What about PPE kits? Why is it that there's a disparity in how PPE kits are distributed between these two groups? It's also about salaries. It's also about who we call as a frontline worker, whose life is more valuable, who we give insurance to, and who we foreground as important in this whole thing. So that is part of the systemic issue, that like that. So the people who are part of that in that tractor, so to speak, they should understand. Of course there are issues within that system, so doctors might say we haven't slept and we haven't got wages, and we are putting our life at risk, and we have not got PPE kits and we have not got insurance. They feel like victims, and it's true that within that system you do not get the benefits which you are supposed to get. You don't get the protection, you do not get the salaries, you do not get the privileges or benefits which you think you should get. But it's also important that you are still within that system, you are still benefiting from the system, and you're also part of that system which is oppressing another group of people. And and I think this it's not, it's not related to the pandemic, but if in terms of looking at structural issues, that is where the discourse around reservations, or the discourse around say for example the death of Dr. Payal Tadvi. So she was an Adivasi Muslim doctor who died because of discrimination, because of extreme amount of harassment. And there's also a group of doctors who say, but we also face harassment, we also face discrimination. If you're a doctor, then it's natural. So why is Payal Tadvi and people talking about her making such a big noise about it? But that's what it's important to understand, that you are still within a system and you're still benefiting from the system, and that system is an oppressive system. It is causing grievous harm and grievous injury to another set of people. And in if so, if JSA Delhi, if you are looking at analyzing caste and occupation, it's also important to understand how occupations within that system, and it could be anything, it could be policymakers, it could be doctors, it is people who are deciding about healthcare system, how they affect and create the system which is oppressing another set of people. Now, then you look at the field itself. Now, the field, say there is an ecosystem. There are people who are surviving on that field. For example, the rabbits in that analogy, they are surviving, and generations have grown up there. But then this person comes from outside, which is set of papers, and he says, "This is my field. I have procured it, and I have." It now belongs to me, and I can sorry, just a minute. I can use it as I please. Okay. Now the rabbits are expected to prove that this belongs to them, that somehow all these resources, whether it's mostly natural resources, belong to them. And they cannot. They cannot prove that this belongs to them, and they cannot in any way offer any kind of resistance, because you can see how unequal the power is. There is a serious power imbalance there. And the person who comes with the papers and the tractor, it's important to understand the relationship with them. So the tractor is not a passive object, it's not something that is there and it is oppressing, it is something that benefits. So it's important to see how capitalism and caste work together to oppress communities. And capitalism, caste is not just a social benefit. It's not that people benefit socially out of the caste system, they also benefit economically. And there is a collusion between these two systems. And in the Indian context, of course, the pandemic has brought out a lot of things which are very visible, and in a way we cannot ignore it. I think earlier it was easier to ignore, it was easier to pretend and imagine that the obvious reasons were not actually the real reasons. But I think with the pandemic, the people who say that these structures don't operate, they can't say it because of lack of information or because of lack of awareness. So, in the context of the healthcare system, if you look at the kind of policies that were made even before the pandemic and also around the pandemic, it's important not just to see the outcomes of those policies. It's important to understand how those policies came to be. So, for example, in the healthcare system was actually played a very important role in some of the decisions around the pandemic. And for example, the lockdown itself. The lockdown and the impact of the lockdown on people, the healthcare system was part of this decision. And for example, in Karnataka we have Dr. Devi Shetty, who made certain statements. So he's on the task force, and he's on the expert committee. And the kind of recommendations that he made, one was to convert large, like 1,000 bedded public hospitals into COVID facilities. So he said NHS in the UK, the National Health Services in the UK, have converted some of their government hospitals into COVID facilities, and we should immediately do that. And he said we should do that tomorrow. And what is the impact of that? Who is accessing these large public hospitals, and what is going to happen to them in this process? Who is going to be responsible for the outcomes of that? And the other thing he also said is doctors and nurses cannot work in COVID facilities for more than 1 week at a stretch. So, according to him, frontline workers are only doctors and nurses. And what about the other workers? Do they not figure, as frontline workers? The other thing that he said as a recommendation is to convert ICU, to strengthen ICU facilities, to invest in strengthening the private sector, to invest in putting up specialists and ventilators and high tech stuff, equipment in the private hospitals. And the government hospitals would function as referral centers. So you have patients who will come to a government facility, they will be screened, they will be given basic oxygen, and then they will be referred to a private facility, and the private facility would be equipped by the government with all these expensive equipment, some of them which would be imported. So this is a policy decision. And the other thing which the so-called policymakers were talking about was to introduce telemedicine. Now, telemedicine has been a long-term demand. Again, if you look at telemedicine from the lens of this whole caste structure, then it gives you a different perspective. It helps you to understand, because the people who benefit from telemedicine are not people who live in urban slums or live in remote rural areas. They cannot access telemedicine. So what I'm trying to present is, I mean, I have 15 minutes, so that's why I thought of this analogy, because it's otherwise it's very difficult to kind of put this into perspective. So what I'm trying to say is that when we look at these occupations, like what we call the unclean occupations, of course they have a lot of problems. And just to list some of those problems, it's loss of wages, it's the delay of wages, and it's such pathetic kind of wages. They're getting 5,000 and 6,000 or 8,000. They're getting harassed by the contractors. They have no labor laws. They have access to no rights, no grievance redressal systems. They face a lot of abuse at work. They face a lot of harassment. And the thing that is not often talked about is the occupational hazard. Occupational hazard is that you have medical or psychological outcomes because of the work that you do. So the pandemic has brought out the kind of occupational hazards that a lot of these workers, whether they're working in mortuaries or burial grounds, or in as house cleaning staff, or people who are cleaning the streets, people who are collecting the garbage, the kind of occupational hazards like needle prick injuries, back injuries, um, sexual harassment, the physical injuries, chemical exposure to a lot of chemical agents, toxins which are just disposed in the hospital without following many guidelines. They are exposed to all of these. So there's a huge list of occupational hazards that these workers are already exposed to. And we've done a study, I request the uh, you know um, um, uh, organizers to kind of share that link. So that has been documented. But it's also important for us to articulate that a lot of these are not like passive processes. It's not something that we look at and we address only these issues. We also have to look at the structures and policies that are operating to keep these systems in place, and look at caste not just an issue of the people who are facing the worst outcomes of it, but also look at caste and occupations that are propagating this and keeping the systems in place and benefiting out of this. So that's all I have to say. Thank you.
Thank you, Sylvia. Thank you for putting this very enrichingly, I would say. I read your report titled Working at the Margins. It was a very well written report, and it actually included a lot of paradigm in the intersectionality. We always used to think about scheduled caste or Dalits to be working in as manual scavengers or sweepers also. So, but the whole spectrum of the occupations that this population is actually working is is extensive, and the only common thing that this population is having, that I earlier mentioned, that they are labor intensive, least paid, most hazardous, and degrading also. You have also very beautifully mentioned this thing that it is not only the caste discrimination that is visible, it is very much ingrained in every occupation. For example, that you mentioned that being a doctor, the doctor will be given things first, though both of them are equally at risk of acquiring the infection. But there is always a preference that is given to a doctor, be it any reason. Most of the times, it is due to their uh, their situation or the position in the society. So this actually, we have all seen this thing, and I have seen this thing in real practice, that this actually makes them feel, this population feels, or I would say my population feel that that it is not demanded for us. They say that we don't need it, we are not desired for it, and that's why we are made to learn that we are not for it. We don't need these kind of, I would say, privileges. About Dr. Payal Tadvi, I would like to mention a very incident that happened with me. When she died, it's like there is a group of medicos on Facebook. It has around more than 1 lakh medical doctors, medical students there. So there's a lot of hue and cry and a lot of hate comments that was coming at the time of counseling of medical PG on that page. So when Dr. Payal Tadvi died, nobody said anything about it. I mean, I posted there, and it's like there was a lot of witch hunting that happens against me, because I said that, is it your morality that let her die, or what was the reason? And they all were trying, I would say, hundreds of medicos, hundreds of doctors were trying to justify the suicide of Dr. Payal Tadvi. And you can imagine that kind of thing that is ingrained everywhere subconsciously about the people coming from the lower socioeconomic sections and the castes and tribes. So we will be discussing this thing more. Coming to our next speaker, we will be having Dr. Satyajit Rath as the next panelist. He is a physician and has worked as an immunologist, initially as a faculty member at the National Institute of Immunology at New Delhi, and his retirement in an honorary capacity at the Indian Institute of Science, Education and Research in Pune. He also works with the government on issues of science and society related policy, with scientific journals, in an editorial capacity with small companies on drug discovery, and with civil society organizations, especially those involved in the science education and those working more broadly at the interface of science and society. Sir, we are glad to have you here. The floor is all yours. Please go ahead.
शुक्रिया. आप सबको सलाम. अमित के बारे में कुछ कहें.
सर, आपकी आवाज़ थोड़ा सा कम है, प्लीज़.
अमित के बारे में कुछ कहें, ये अभी तो बस के बात नहीं है, शायद कुछ देर बाद. जो मुद्दा आज बहस में है, उसको लेकर मैं उतना काम नहीं करता जितना करना चाहिए. And as a result, I'm a little uncertain about what I have to say and my status to say this, my credibility to say this. And I bookmark that right at the beginning. I dearly wish Bezwada Wilson was with us with an extremely grassroots perspective of what caste and occupation face in these COVID times. That said, I'm going to make 3 separate points. One, which is a point of perspective and attitude more than anything else. किस दृष्टिकोण से हम महामारी के बारे में सोचते हैं, इसको लेकर मैं एक मुद्दा आपके सामने रखूंगा. The second point I will make is a point that would have been beloved of Amit, जो कि कहा करते थे, अबे बतिया बहुत कर रहे हो, कोई सबूत है? And I will therefore try to make a point about evidence, data, and information regarding caste and occupation in COVID times. And my third point will be about what the perspective regarding caste and occupation would be in the way forward for health activist movements building on lessons of COVID times. So let me start with the attitude issue. COVID-19 की महामारी है, SARS-CoV-2 विषाणु का नाम है, और ये फैलता कैसे है? तो मैं अक्सर कहता हूं, कई साथियों ने सुना होगा कि कबीरे का भगवान है, खूंजी होवे तो तुरते मिली हो, पल भर की तलाश में, कहत कबीर सुनो भाई साधो, सब श्वासों की सांस में. तो हरेक की सांस से दूसरे की सांस में पहुंचता है. This is ostensibly the great leveler because it is transferred from breath to breath. It is transferred because we are a community together, and therefore it is a great equalizer. And yet, many of us are more equal or more unequal than others. But think about, for a moment, this notion of breath-to-breath spread. And inevitably, when we think about an epidemic, pandemic is simply a peculiar word to say it's a worldwide epidemic. When we think about an epidemic and we think about the spread of disease, there is a peculiar evocative word that comes up in English, contagion. और contagion के लिए, उस संकल्पना के लिए हिंदी में जो शब्द है, उसे लेकर मैं इस महामारी की शुरुआत से परेशान रहा हूं, क्योंकि वो शब्द है छूत. तो छूत, with all its echoes of institutionalized social injustice, with all its reverberations of organized socioeconomic exploitation, is also a word that we think of as a purely technical word for the spread of communicable diseases. Inevitably, therefore, I suggest to you, I think that we need to worry about whether implicit biases that all of us carry as culturally inherited baggage might be coloring how we think about, how we speak about, and how we respond to the pandemic. There is much to be said about this, but I'm going to leave this there, and आशा है कि हम में से कई श्रोता जो मुझसे ज्यादा इन सब मामलों के बारे में सोचते हैं, वो कुछ इस मुद्दे पर ज्यादा बात रखेंगे। दूसरा मुद्दा मैं करना चाह रहा था वो ये है कि आंकड़ों का खेल थोड़ा देखें। कहां से शुरुआत करें? तो शुरुआत यहां से करें कि कोविड-19 के टीके अब नजर में हैं, हाथ में नहीं है लेकिन नजर में हैं। और जहां तक टीके नजर में हैं तो बातें जोर शोर से हो रही हैं कि सिर्फ टीके नजर में नहीं होने चाहिए, टीकाकरण नजर में होना चाहिए। One should not simply think about vaccines, one should think about the more practical issue of implementation of vaccination. And in order to think about implementation of vaccination, in a situation in which we have globally helplessly committed ourselves to a market capitalist pathway of responding to a pandemic, by abandoning our societal responsibilities of making vaccines and providing them to the private sector. This is underlined by the fact that of the 200 odd efforts at developing vaccine candidates that are going on across the world, with the doubtful exceptions of a few Chinese companies, there are no efforts that do not have private sector manufacturing partnerships. In effect, we are depending on the private pharmaceutical sector to provide the instruments that we can use to deal with the pandemic. तो ठीक है, जब प्राइवेट सेक्टर के पास जाओ तो जाहिर है कि बात मुनाफे की आएगी, और मुनाफा तब ज्यादा होता है जब सप्लाई कम होती है। तो जाहिर है कि वैक्सीन्स की सप्लाई कम होगी। अब अगर वैक्सीन्स की सप्लाई कम होगी तो जाहिर है कि बतौर देश की सरकार आपको सोचना पड़ेगा कि किसको पहले वैक्सीन दें। तो कोई अचरज नहीं है कि भारत की सरकार बड़े जोर शोर से सोच रही है कि वैक्सीन पहले किसको देनी चाहिए। जितनी वैक्सीन्स नजर में हैं उनमें से जो कोई पहले हाथ में आए पहले किसको देनी चाहिए। And the answer to this has been, as both Abhishek and Sylvia have alluded to, कि frontline workers को देनी चाहिए, खास करके स्वास्थ्य कर्मियों को देनी चाहिए। तो सवाल ये उठता है कि ये जो फ्रंटलाइन हेल्थ केयर वर्कर्स हैं वो कितने हैं, कौन हैं और कहां हैं? And this is where we run into great difficulties. You start trying to count and identify, or more correctly, identify and count healthcare workers. And on the one hand, you have this global number that representatives of the union government have been reported in the media as claiming that there are 10 million, 1 crore हैं healthcare workers, जिन्हें तुरंत टीके मिल जाएंगे। अच्छा, कैसे गिना? तो फिर बात ये होती है कि केंद्र सरकार ने राज्य सरकारों से पूछा, राज्य सरकारों ने जिला प्रशासनों से, जनपद प्रशासनों से पूछा, और प्राइमरी हेल्थ सेंटर से जानकारी मंगवाई कि आपके पास कितने स्वास्थ्य कर्मचारी हैं। इसमें सवाल ये उठता है कि किसको प्रशासन स्वास्थ्य कर्मचारी मानता है। और जब अभिषेक अपनी बात रख रहे थे तो मुझे फिर दोबारा इसी बात का एक पहलू महसूस हो रहा था कि जो उन्होंने उदाहरण दिया कि मारचूरी में जहां पे ऑटोप्सी होती है, तो जो वहां का कर्मचारी है जो आमतौर से काटने का, निकालने का, हथियाने का काम करता है, वो कितनी बार अस्पताल का, मेडिकल कॉलेज का सुनियोजित कर्मचारी होता है और कितनी बार वो ठेकेदार का दिया हुआ कर्मचारी होता है। How many times is this kind of labor recognized labor, and how many times is it unrecognized because in the evolving patterns of gig capitalism, it is contractual, casual, unrecognized labor. And inevitably, as you begin to look at these numbers, you begin to see India's familiar, depressing intersection of caste and occupation. Add to this the second problem, which is survey after survey has shown that more than half of all healthcare visits in India, the numbers vary from survey to survey, but more than half of all healthcare visits in India, which are, after all, what we see as the risk in pandemic times, are visits to private sector healthcare. So you ask, is private sector healthcare purely physicians or physicians and nurses? Are there no equivalents of the, let me use the proper term, the nursing aides in hospitals, in small nursing homes? Where I am sitting in Maharashtra are commonly referred to as the mamas and the mausis in जहां अस्पतालों में जो कोई मरीजों को निजी सेवा देनी पड़ती है, नहलाना पड़ता है, बेडपेन देना पड़ता है, यूरिन पार्ट देना पड़ता है, सफाई करनी पड़ती है, कपड़े बदलने पड़ते हैं, ये सब सेवा कौन देता है? तो जैसे मैंने कहा, महाराष्ट्र में उन कर्मचारियों को मामा मौसी कहते हैं, बड़े अच्छे शब्द हैं। तो इन मामा मौसियों में को लेकर दो सवाल उठते हैं। एक, इनके आंकड़े कितने हैं, कहीं दर्ज हैं? और दूसरा, what is the caste distribution amongst these? Anecdotally, unsurprisingly, the so-called lower castes, of course, predominate in these. अब सवाल ये है कि क्या केंद्र सरकार की गिनती में ये लोग गिने गए हैं? तो जनस्वास्थ्य अभियान की ओर से ये सवाल पूछना बेहद जरूरी बात है कि जिन्हें आप स्वास्थ्य कर्मचारी बतौर मान के उनके टीकाकरण के बारे में सोच रहे हैं, उनमें क्या सचमुच सारे स्वास्थ्य कर्मचारी गिने गए हैं या नहीं? और अगर नहीं गिने गए हैं तो जनस्वास्थ्य अभियान की ओर से हमने ये कहना चाहिए कि गिने जाएं और यूं इस तरीके से गिने जाएं और उनके टीकाकरण के बारे में कोई सुनियोजित व्यवस्था हो। यह हुई दूसरी बात। इसका एक बड़ा सख्त कारण यह भी है कि हम महामारी को बतौर छूत के सोचते हैं, यानी कि संक्रमण संसर्ग से, नजदीकी से होता है। तो ये सवाल पूछें कि स्वास्थ्य कर्मचारियों में डॉक्टर से लेकर नर्स तक, नर्स से लेकर जिन्हें मैं नर्सिंग एड्स कह रहा हूं, जिन्हें मैंने मामा मौसी कहा, उन कर्मचारियों तक सवाल ये पूछें, इफ वी काउंट the amount of intimate time with patients during their working day that all of these different categories of health workers spend, which of these categories spends the most intimate time professionally with patients and is therefore quantitatively maximally at risk? And while I have yet to find such an analysis, I think that as Jan Swasthya Abhiyan, this is the kind of information that we should be basing our demands on. ये हुई दूसरी बात। तीसरी बात मैं सामने रखना चाह रहा हूं, वो ये है कि जब हम देख रहे हैं कि न कि सिर्फ हमारी सरकार, भारत की सरकार, देश भर की सरकार, देश भर, दुनिया भर की सरकारें महामारी के खिलाफ जो कदम उठा रही हैं, उनके बारे में अगर सोचें, उन कदमों के बारे में अगर सोचें, तो महसूस होता है कि ये बतौर क्राइसिस मोड के हैं। They are all responses in crisis mode. जैसे कि कहीं भूचाल हो गया और उस भूचाल के बाद जो हानि हुई है उससे निपटने के लिए आपने छोटे समय के लिए कुछ व्यवस्थाओं की तजवीज की है। मेरी परेशानी ये है कि महामारी हमें जो सबक सिखा रही है वो इससे बिल्कुल उल्टा है। वो सबक ये है कि हमारी स्वास्थ्य व्यवस्थाएं वैसे ही पूर्ण है, उतनी नहीं है जितनी होनी चाहिए, और इसलिए 6 महीने, 1 साल भर के लिए कुछ नई व्यवस्थाएं, कुछ नए कोविड सेंटर, कुछ स्वयंसेवी संस्थाओं के मार्फत काम करा के हम कोविड पर विजय पाए और फिर जैसे पहले था वैसे हो जाए, ये एक बुनियादी गलती है और जन स्वास्थ्य अभियान ने इसके खिलाफ अपनी आवाज उठानी चाहिए। ये बात मैं कास्ट और ऑक्यूपेशन की बहस में क्यों रख रहा हूं? मैं इसलिए रख रहा हूं because here is what we need, what we have learned from the identify, contact trace, test, isolate programs that we know should work in a just and equal society and do not properly work because they are implemented with all the prejudices of an unjust and unequal society. But if they are to work, then what we need is community health outreach as an integral, equitable component of our public healthcare system, not simply in crisis mode response, but as a permanent, well-established, just and equitable public healthcare system. और अगर ये होना है तो हमारी मांग सरकार से ये होनी चाहिए कि ना सिर्फ अस्पताल बनाएं, ना सिर्फ टेस्ट इंस्ट्रूमेंट्स खरीदें और उनकी डिस्ट्रीब्यूशन करें, बल्कि नौकरियां होनी चाहिए, सरकारी नौकरियां होनी चाहिए, हर एक स्तर पर होनी चाहिए, ऊपर से लेकर यानी कि डॉक्टरों से लेकर सबसे ग्रास रूट तबके तक, जहां की हेल्थ आउटरीच सबसे ज्यादा जरूरी है, वहां तक वी नीड permanent, stable, skilled, dignified employment for health outreach into the community by people within the communities, so that there is dignity and trust in the interactions. And in order to do this, we need not simply the investment of financial resources, not simply the expansion of technical resources. We need a proper long-term state commitment to appropriate human resources. And at the end, let me ask you the rhetorical question: who is going to form the backbone of these resources, reaching with trust and dignity into the communities of India? And we know the answer to that. The last point I will make simply in memory of Amit. And that is, एक और हम आंकड़ों के लिए आंकड़े खोजते हैं हम लोग, दूसरी ओर आंकड़े हमें बहकाते भी हैं। तो यूं पूछिएगा कि महामारी फैलती है, कितनी फैली है, इसके भी तो कोई आंकड़े होने चाहिए। तो दिल्ली में ये कहा जाता है कि दिल्ली शहर में सीरो सर्वेस किए गए हैं और बताया जाता है कि कुछ 30-35% लोग कोविड-19 से वाकिफ हो चुके हैं। इसी तरीके का एक सीरो सर्वे जहां मैं बैठा हूं पुणे में, वहां भी किया गया था। आंकड़े ये दिखाते हैं कि सब सांसों की सांस में 50% तक पुणे का अगर देखें तो महामारी का विषाणु पहुंचा है। लेकिन आंकड़े जितना दिखाते हैं उतना छुपाते भी हैं। तो एक शहर की एक एक सब वार्ड में ये पूछिएगा कि सब वार्ड है, आपने सैंपलिंग करी हुई है और उस सैंपलिंग के दौरान आपको ये दिखाई दिया है कि 50% लोगों में लक्षण दिखाई दिए हैं कि कोविड-19 के विषाणु के साथ उनकी जान पहचान हो चुकी है। तो अच्छा, हर मोहल्ले में यही बात है ना? जब झुग्गी झोपड़ियों में जाओ तो 70-75% आंकड़ा है, और उसी झुग्गी झोपड़ी के साथ दीवार की उस पार जो अपार्टमेंट बिल्डिंग है वहां जाओ तो 25-30% में है। लेकिन हम हैं कि कहे हैं 50% में है। समता के तले छुपी हुई विषमता को देखना ना भूलें। अमित ने सबक सिखाया था मुझे, आज इस अवसर पर उसे दोबारा याद कर रहा हूं। इतना कह के रुक जाऊंगा। सबको सलाम।
Thank you, sir. Thank you, Satyajit, for these very good informations और ये जो चीज़ें हमें आगे करनी है इस चीज़ को पेन डाउन कराने के लिए। लेट मी समराइज योर वर्ड्स, और मैं कुछ अपनी फैक्ट चेक्स जो कि मैंने भी फील्ड्स में देखे हुए हैं मैं भी उसके साथ बताना चाहूँगा। साइंटिफिक एविडेंस एक्चुअली हमारे पास जो नंबर है SC STs या फिर अदर बैकवर्ड क्लासेस का, वो सिर्फ नंबर इसलिए आता है ताकि रिजर्वेशन वाली बात की जा सके, उसके अलावा कोई नंबर हमारे पास नहीं होता है। मैं कल इस वेबिनार के लिए देखना चाह रहा था कि रेंज ऑफ ऑक्यूपेशंस क्या है इन कास्ट में और कितना कितना % है। कहीं पे इस चीज़ की बात ही नहीं है, किसी भी डॉक्यूमेंट में इस चीज़ की बात ही नहीं है कि रेंज ऑफ ऑक्यूपेशन क्या है, कितना है। मतलब ये तक मेंशन नहीं है कि कितनी तरह के ऑक्यूपेशंस हो सकते हैं, ठीक है। दूसरी बात, नंबर तो बहुत दूर की बात है। आई टोटली एग्री विद योर पॉइंट कि साइंटिफिक एविडेंस की तो कोई बात ही नहीं करता। क्वांटिटेटिव की बात तो हम बाद में करेंगे, क्वालिटेटिव की बात भी नहीं हो रही है। क्वालिटेटिव स्टडीज़ तक अवेलेबल नहीं है और ज़्यादातर स्टडीज़ बहुत मतलब ग्लैमरस टॉपिक्स पे जाके रुक जाती हैं। मुझे ऐसा लगता है हमारी भी गलती बहुत ज़्यादा है। दूसरी चीज़ जैसे सर आपने बताया कि फ्रंट लाइन वर्कर्स में हम लोग कंसीडर कर रहे हैं कितने लोगों को वैक्सीनेट करना चाहिए, बिल्कुल सही बात है कि उसमें तो हम काउंट ही नहीं कर रहे हैं। हम सैनिटरी वर्कर्स को काउंट नहीं कर रहे हैं, हम लोग उन सैनिटरी वर्कर्स को काउंट नहीं कर रहे हैं जो कि रोड पे झाड़ू लगा रहे हैं, हम उसे काउंट नहीं कर रहे हैं जो कि मॉर्चरी में काम कर रहे हैं, हम उसे काम नहीं कर रहे हैं जो कि एम्बुलेंस से डेड बॉडीज़ को क्रेमिनेशन के लिए लेके जा रहे हैं या फिर क्रेमिनेशन ग्राउंड पे जो काम कर रहे हैं, किसी को हम लोग काउंट कर ही नहीं रहे हैं। तो उनको काउंट नहीं करें तो उनको दैट मीन्स ये कि अगर मैं ये डिड्यूस करना चाहूँ उन्हें वैक्सीनेशन तो नहीं मिलने की है। और उसके अलावा मैं ये एक एग्जांपल देना चाहूँगा। मैं एक बार फील्ड में था, एक सब सेंटर पे नज़र गई मेरी, तो वो एरिया जो था वो टिपिकल वाल्मीकियों का एरिया था। मुझे लगता है आप लोग को वाल्मीकियों के बारे में पता होगा रिसेंट इंसिडेंट्स की वजह से। तो मुझे ऐसा लग तो वो सब सेंटर था, वहाँ पे टेक्निकली पोस्ट रखी गई कि जो उनकी आशा हैं वो रहेंगी मतलब शेड्यूल कास्ट। अब शेड्यूल कास्ट में वाल्मीकियों के गाँव नहीं, मोहल्ला जैसा था, सेमी अर्बन था। तो उन्होंने क्या किया कि वो जब पंजीरी बाँटने आती थीं, वो वाल्मीकि नहीं थी, वो उससे अपर वाली एससी थी, ठीक है? तो वो ऐसे करके उठा के उनके हाथ में डाला करती थी। उनका हाथ बीइंग अ एससी दूसरे नीचे वाले एससी से टच नहीं होना चाहिए। तो मैं इस इंसिडेंट को यहाँ पे इसलिए बताना चाह रहा हूँ क्योंकि जब वैक्सीनेशंस की नौबत आएगी, पहली बात तो एससी सब सेम है, नहीं मिलेगी। जब उसमें भी मिलने की नौबत आएगी तो ये सर्विस डिलीवरी इश्यूज की तरफ किसी का ध्यान नहीं जाएगा। और मैं लिटरली जिस मोहल्ले से मैं आता हूँ उस मोहल्ले में तो ये बोला जाता है कि हमें तो कोविड हो भी नहीं सकता, क्योंकि वो तो डेली घूम रहे हैं बाहर। उनका ये मानना है कि ना उन्हें कुछ मिलेगा, ना उन्हें कोई आस है, ना उन्हें कुछ चीज़ से कोई फ़र्क नहीं पड़ता, बिकॉज़ दिस इज़ देयर नॉर्मल लाइफ, एवरीथिंग हैज़ बीन नॉर्मलाइज्ड टू देम। तो इट इज़ ऑल अबाउट नॉर्मलाइजेशन। सर मैं आपने आपने एक बहुत अच्छा टॉपिक रखा था कि एक बस्ती है, एक बार है बीच में, एक साइड एक पॉश कॉलोनी है, उसकी दूसरी साइड एक बस्ती है जहाँ पे दलित या फिर लोअर कास्ट रहते हैं। इंसिडेंट मैं आपको सच बता रहा हूँ, फिर भी मैं आपको मतलब कॉन्ट्राडिक्ट कर रहा हूँ, सॉरी सर, कि इंसिडेंट ज़्यादा पॉश कॉलोनी में ही होगा। मैं रीज़न बताऊँ क्यों? बस्ती वाले टेस्ट ही नहीं कराएंगे, उन्हें टेस्ट मिलेंगे ही नहीं। तो वी नीड टू अंडरस्टैंड दीज हार्श रियलिटीज़ कि हमने उस बारे में सोचा ही नहीं कभी। तो मैं इस चीज़ को यहाँ पुट फॉरवर्ड कर रहा हूँ। तो अब आगे बेजवाड़ा सर ने एक्चुअली ही इज़ नॉट एबल टू जॉइन द कॉल बिकॉज़ he has to rush to somewhere because of some emergency. We have someone who has worked with him on a study, and we are now going to play the video first, and we will be inviting Miss Kanika Singh to put forward the findings of that research. I would request Garge to play that video, please. Thank you.
छूत का भी बर्ताव रखते हैं कि छोटा कास्ट है, छुआ जाएगा मेरा घर, ऐसा हो जाएगा, ऐसा हो जाएगा।
मेला साफ करते हैं तो वैसा ही बर्ताव करते हैं। जब आगे से लोग चलता है, हम लोग को देख करके घृणा मानता है। समय पर वेतन भी नहीं मिलता है।
कभी 20 रुपए, कभी 30 रुपए कहते थे, अगले महीना में लेना। रोटी लेने जाते थे तो यार ना लेना, कल लेना है कि भाई।
ना गैस सिलेंडर मिला है, जितनी योजनाएं आप सरकारी दे रहे हैं सब हम लोगों को कुछ मिलता ही नहीं है, तो हम लोग क्या करें।
बोलने का तो बहुत सारा बात बोलता है, ये दिया वो दिया, हम लोग को कुछ नहीं मिला है अभी तक। कोई राशन पानी का भी उतना व्यवस्था नहीं है। सबको तो बोल रहा है कि पैसा मिलता है, ये मिलता है, वो मिलता है, हम लोग को तो एक को पैसा नहीं मिला है। तूने माया है कि उधर बंट रहा है, उधर बंट रहा है, लेकिन हम लोग को कभी कुछ नहीं मिला है।
स्कूल में जाते थे नाम लिखाने के लिए भाई, तो बच्चे में नहीं नाम लिखते थे, छूत विचार करते थे।
क्या करेंगे, यही काम आश्रय, हम लोग और कोई काम देवे नहीं करेंगे नीचे जा सोच के। सरकार की तरफ से बोले कुछ मदद मिलते हैं तो हो जाते हैं, तो शायद अपना कोई रास्ता अगर चुन लेते हैं कि हाँ चलिए सरकार तरफ से मदद मिले, कोई अपना बिजनेस बढ़िया खोल ले, थोड़ा सा हम लोग भी।
छूट चलती है इसीलिए नहीं कर सकते हैं, और दुकानों भी रख लेंगे तो कोई सामान नहीं लेगा हमसे।
खाना पीना, आदमी को राशन पानी जो पहले चलते थे वो सब भी बंद हो गए हैं। अभी कपड़ों से प्लस राशन मिल रहे हैं, वही से भी गुजारा कर रहे हैं किसी तरह। निमक बात माँ बाप लगते हैं, प्लस फिर जो लेटरिन बाथरूम धोने जाते थे वो भी सब मना कर दिए कि कोरोना की वजह से भी नहीं आना, बीमारी फैलेगा, कोरोना हो जाएंगे, इसीलिए सब भी मना कर दिए। घर बैठे बाल बच्चा को पढ़ाई लिखाई में भी दिक्कत हो रहे हैं। अभी तो कुछ नहीं कर रहे, थोड़ा बहुत जाते हैं घूमते फिरते हैं तो 2-4 पैसा का काम हो जाता है, 50-60 रुपये का, तो उसी में से जो चला लेते हैं साग सब्जी। कभी मिलते हैं कभी नहीं मिलते हैं, देखते हैं दरवाजा में तो ढुकने देवे नहीं करता है, उधरे रहो जा भी काम नहीं करा, जो भी करा नहीं करता है वो भी नहीं कराते कि बीमारी फैल जाएंगे। सरकार तरफ से तो कुछ मदद मिल नहीं रहे कि घर बैठा खा लेंगे अपना। सरकार तरफ से कुछ मदद मिलते तो गली गली हम लोग को भटकना नहीं पड़ता, घूमना नहीं पड़ता।
ना तो मेरे पास कुछ धंधा है, ना पानी है साहब, और ना मुझे कुछ मजदूरी मिलती है अगर तो बोलते हैं कि जिम्मेदार समाज है, इसको कोई काम नहीं देना है।
कोई भी काम नहीं कर रहा है अभी लॉकडाउन में, तो किसी को कोई काम मिल ही नहीं रहा है। मेरा भी काम बंद है, बहुत दिक्कत हो रही है अभी।
I demand government, they must take the dignity, self-respect and right to life of the scavengers must be the priority, national priority. So those agencies, organizations and individuals, the part of the WASH, must take a kind of a time-bound action plan. There they have to put the very clear priorities. Then that they have to see that it is happening across the globe, not just in one place.
Very interesting video and so many perspectives from this video. Now, I would like to invite Miss Kanika Singh to shed some light on the study that is conducted by her and Mr. Bezwada Wilson. And sorry, I don't have her introduction. Please, Kanika, introduce yourself and share the findings with us.
Hello everyone, thanks Dr. Abhishek. I'm Kanika. I work with WaterAid and I'm working on various research and policy initiatives around the issues of sanitation and also sanitation workers issues. So today I would like to take this opportunity to share findings from a study we did recently jointly with the Urban Management Center, and that was focusing on the challenges faced by sanitation workers during the COVID-19 pandemic. I hope the slides are visible to all.
Yes, they are.
Thank you. I'll not go into much details about the study methodology. We interviewed around 95 sanitation workers and also some officials from urban local bodies across different states in India. And we covered 9 different categories of sanitation work. So these include different forms of work like sweeping, cleaning of drains, cleaning of sewers and septic tanks, and also workers working in different kinds of settings. Like we covered workers who were working in hospitals and quarantine centers, in community toilets, institutional toilets, and people who were into rat picking and latrine cleaning, etc. So the data collection was done during June and July this year. So just to give some brief highlights, so we learned from a study that although there was a fair level of awareness among sanitation workers about the COVID symptoms and also some of the preventive measures, but there were other aspects around COVID prevention which we thought there should be some more emphasis on, particularly due to the kind of work sanitation workers do and the kind of risks they face. So these include information about reuse and disposal of PPE, handling and disposal of waste, etc. And about personal protective equipment, so we saw that although many workers did have some sort of personal protective equipment with them, but the specific kinds of equipment which was required for their category of work were not available with most of the workers, including hospital work, including the sanitation workers who were working in hospitals and quarantine centers, who in the COVID context, they are one of the most vulnerable persons, and even they did, some of them just had a simple mask and they did not have the other equipment which is essential. And in many cases, we also saw that even if people had some PPE, they were not able to use it regularly because they were facing issues like suffocation and sweating, etc. So the PPE provided to them was not user friendly in many cases. And also in some cases, we also saw that even if PPE was provided by employers, but that was not adequate and the workers had to make their own arrangements in some of the cases. So next, we also looked at the hand hygiene practices. So we all know that washing hands is one of the most important prevention measures for COVID-19. But in our study, we saw that 40% workers lacked access to a hand washing station with water and soap at the places of their work. This is because many of these workers, like sweepers and cleaners of sewers and septic tanks, etc., so they have to go to multiple sites in a day and they do not have these kind of facilities where they can wash their hands regularly. We also observed that only less than 20% of the workers reported any sort of thermal screening or medical checkup they underwent during that time, and none of the informal workers were being covered under this. Only the permanent staff or the contractual staff who were engaged by urban local bodies did have some sort of medical facilities for them. We also looked at how the pandemic led to implications on the livelihoods and on their finances. So 13% workers in our sample, they were completely out of work since the lockdown had started, and income had reduced for 30% workers. Some people were facing delays in their payments, and many of them even reported that they had to borrow in order to deal with the financial constraints. So that further puts them into more debt. And especially we saw that the impact was the most severe for the informal workers because they did not have any support from the persons or institutions they were working for, and they did not have any kind of backup or safety net. So we saw that dry latrine cleaners and rag pickers were among the most affected. And even in the video, we saw that the women said that they were not able to get work during this time, and one of them even said that hunger is more dangerous than coronavirus, and their situation was very bad. And rat pickers similarly were also facing a similar kind of challenges. I would also like to highlight that among the sanitation workers, the women were facing even more additional challenges than their male counterparts. So, in our study, we observed that among the informal workforce, the representation of women was higher as compared to males. So that meant that they had lesser income security, and they also had lower coverage in terms of the work benefits, the insurance coverage, and other support measures from their employers. Uh, so which basically puts them at a higher level of risk and vulnerability in this situation. Some women also reported having additional difficulties during menstruation, as when they were going out for work, so many public toilets were closed during the lockdown, and they were not able to get toilet facilities. And some reported that because of the increased workload, they were facing physical discomfort uh, uh, during the menstruation. And some women also reported that because of the additional workload in the pandemic time, they were facing difficulties in taking care of their household responsibilities, and in absence of any form of support at home, uh, they were they were finding it difficult to take care of their children. They were forced to leave their children behind when they were going out for work. So I would like to end with a summary of the recommendations which emerged from the study. The detailed study findings and recommendations can be seen in the report. I think Raman has already shared the link of the report in the chat box. We are recommending that in the immediate context, uh, there needs to be greater attention to the health and safety of sanitation workers, and their health and safety should be given as much importance as the other health workers are given, because they're also facing a lot of risks in this time. And further, we should have some social and financial protection measures for them in place, especially for the informal workers. They need even more additional support. And in the long term, we recommend some systemic and policy level measures which would help in ensuring their health and safety. So that includes coming up with user-friendly PPE and formalizing the work arrangements, etc. Uh, Thank you. Thanks for this opportunity for sharing, and glad to share more information with you.
Thank you, Kanika, for sharing these very enriching findings. Uh, yeah. So, coming back to this study, it is a very interesting study. I must say that it is a very representative study, and women as manual scavengers has a very, I would say, ignored aspect when it comes to research and reporting also. Uh, मैं इस बात पे थोड़ा सा तवज्जो देना चाहूँगा कि मैनुअल स्कैवेंजर्स एक्चुअली होते क्या हैं। मैनुअल स्कैवेंजर्स बेसिकली हम लोग ये कंसिडर करते हैं जो कि मैन होल्स में जाते हैं, नाले साफ करते हैं या पॉट साफ करते टैंक साफ करते हैं, उन्हीं को मैनुअल स्कैवेंजर्स यूजुअली बोला जाता है। बट यूजुअली ये मैनुअल स्कैवेंजिंग सिर्फ वहाँ तक नहीं रहती है। फीमेल्स जो मैनुअल स्कैवेंजिंग्स में होती हैं वो दोनों तरीके से हो सकती हैं, जो कि या तो मैन होल्स को साफ करना, ये टैंक्स में भी कभी कभी जाती हैं वो, नहीं तो उनका जो मेनली काम होता है जो कि नॉर्थ इंडिया में बस्ती कहा जाता है, मतलब जो प्रोफेशन जो जिसे बोला जाता है वो कहते हैं बस्ती झाड़ने जाना। तो बस्ती झाड़ने जाने का मतलब ये होता है कि वो जा रही हैं किसी का घर साफ करने, किसी की लैट्रिन साफ करने, और जहाँ पे पॉट्स, अब तो पॉट्स काफ़ी ज़्यादा हो गए हैं, लैट्रिन्स हो गई हैं, नहीं तो जब लैट्रिन्स नहीं हुआ करती तो आज भी जो सिर पे मतलब लैट्रिन को लेके कैरी करके दूर जाके डंप करना, बेसिकली जो मैनुअल स्कैवेंजिंग का जो नाम आया था वो वहाँ से आया था। तो वो पूरी डायनेमिक्स वहाँ से अलग हो जाती है, और इस पैंडेमिक में women as manual scavengers और men also, ये डायनामिक इसलिए इम्पॉर्टेंट है क्योंकि सबसे पहली बात कि उनको यूजुअली घर में तो पहले भी नहीं घुसने दिया जाता था, और अब तो बिल्कुल नहीं घुसने दिया जाता। तो जितना भी उनका जो शिट है, आई वुड यूज दिस टर्म शिट, वो बाहर रख दिया जाता है, वो वहाँ से कैरी करके लेके जाएंगे, तो उनके लिए बहुत ज़्यादा डिफरेंस नहीं है। क्योंकि वो अंदर एंटर नहीं कर रहे हैं तो उनकी जो फाइनेंसेस हैं वो तो एकदम कम हो गए। दूसरी चीज़ ये है कि हाँ, लेकिन जहाँ पे जैसे सत्यजीत सर ने मेंशन किया था कि जब कोई होता था तो उसकी केयर टेकिंग कौन करता था? तब यही मामू, मौसी और अगर नॉर्थ में बोलेंगे तो भैयाज़ एंड बुआज़ जो होती हैं, यही केयर टेकर्स की तरह काम करती हैं क्योंकि जो उनकी शेड साफ करना, उनकी नहलाना-धुलाना वो। इस टाइम पे मैंने कुछ चीज़ें नोटिस की, आई कैन नॉट गिव यू द नंबर्स कि जब कोविड पेशेंट्स हो जा रहे हैं एल्डरली, जो कि मतलब पीपल दोज हु कैन अफोर्ड, उनकी केयर टेकिंग में भी यही लोग काम कर रहे हैं, यही कास्ट काम कर रही है क्योंकि वो हमेशा से उस चीज़ को करते आई है और उन्हें वही 50-100 रुपये मिलते हैं पर डे के हिसाब से। और उन कोविड पॉजिटिव पेशेंट जो कि होम बेस्ड हैं, उन वो लोग वहाँ पे काम कर रहे हैं। तो मतलब मैं ये नहीं कहूँगा कि बहुत रिप्रेजेंटेटिव है ये चीज़, बट हाँ, मैंने इस चीज़ को भी नोटिस कई जगह किया है। दूसरी चीज़, एक जो इश्यू है हैंड वॉशिंग का, हैंड वॉशिंग के इश्यू में हम लोग को और ज़्यादा डेप्थ में जाना चाहिए। सेफ वाटर अवेलेबिलिटी थी ही कहाँ लोगों के पास? स्लम्स में, बस्तियों में कभी भी सेफ वाटर की अवेलेबिलिटी ही नहीं थी। हैंड वॉश, द होल नोशन ऑफ हैंड वॉशिंग इज़ वेरी कंटेक्चुअल, आई वुड से। सेफ ड्रिंकिंग वाटर ही नहीं है, हाथ धोने का पानी नहीं है, तो हैंड वॉशिंग तो हम लोग इमेजिन कर ही नहीं सकते हैं। और इसी वजह से वो सारा सीन जो होता है कई जगह पे बहुत ज़्यादा क्वेश्चनेबल हो जाता है। एंड थैंक्स टू पुट दैट पॉइंट कनिका। अबाउट द दिस मास्क थिंग, मास्क जिन लोगों को मिल जा रहा है, दे आर वेरी प्रिविलेज्ड। अब तो सबसे अच्छी बात कोविड में मुझे ऐसा लगता है कि जो क्लॉथ मास्क का यूज़ है वो बहुत अच्छा था। अगर क्लॉथ मास्क काम नहीं कर रहा होता तो लिटरली कोई दलित तो मास्क यूज़ ही नहीं कर पाता, एफर्ट ही नहीं कर सकता था। तो व्हाट दे आर डूइंग कि जब वो बस्ती झाड़ने जाती हैं, वो फीमेल्स और मेल्स भी, तो क्या करती हैं, अपने दुपट्टे को मुंह पे ढक देती हैं। जो हम मास्क यहाँ पे टर्म कर रहे हैं वो एक्चुअली मास्क भी नहीं है, वो एक ढांटा है, उसे हम लोग ढांटा बोलते हैं नॉर्थ इंडिया में। तो वो ढांटा डेली जो दुपट्टे को मुंह, जो वो डेली नॉन कोविड टाइमिंग्स पे भी करती थी, वो उस चीज को आज भी वहीं पहन के कर रही है, उनके लिए कुछ चेंज नहीं हुआ है। तो आज भी वही उसी ढांचे को मान के काम कर रही है। बट लकीली इस पॉपुलेशन के लिए कि वो डाटा काम कर रहा है, क्योंकि क्लॉथ मास्क की तरह वो काम करता है, क्योंकि मल्टीपल लेयर्ड वो डाटा ओब्वियसली अपने आप हो ही जाता है। तो ये कुछ बहुत ऐसी ग्राउंड रियलिटीज़ हैं जो कि मतलब हम लोग इससे बहुत परे हैं और जो बहुत ज़्यादा इस पेंडेमिक को अफेक्ट कर रही हैं। मैं इससे आगे कुछ चीज़ें और मेंशन करूँगा कि हमने अभी तक मैनुअल स्कैवेंजर्स या फिर उन्हीं लोगों के प्रोफेशंस की बात की, या फिर हमने बात की जो लोग मतलब सैनिटरी वर्कर्स हैं या हॉस्पिटल में सैनिटरी वर्कर्स हैं, उनकी बात की। देयर इज़ अ रेंज ऑफ ऑक्यूपेशन दैट पीपल आर एक्चुअली वर्किंग ऑन व्हेन इट कम्स टू लोअर कास्ट। फॉर एग्जांपल जुलाहा, धोबी, या फिर मतलब आई शुड नॉट यूज दीज टर्म्स, मतलब अगेन आई एम सो सॉरी अबाउट इट, आई अपोलोजाइज। बट जो इस सारे शेड्यूल कास्ट से आते हैं, उनके पूरे पूरे प्रोफेशंस तबाह हो चुके हैं। दे आर इकोनॉमिकली वेरी डिस्ट्रेस्ड, प्लस क्योंकि उनके पूरे इकोनॉमीज, उनका पूरा सोर्स ऑफ इनकम खत्म हो चुका है और उनकी तरफ अभी तक ध्यान ही नहीं दिया जा रहा। अब वी बीइंग कमिंग फ्रॉम दैट पब्लिक हेल्थ बैकग्राउंड या फिर एक्टिविज्म, जैसे हम लोग क्या कहते हैं कि भाई व्हेन इट कम्स टू दलित, एक ही दिमाग में आता है बात कि मैनुअल स्कैवेंजिंग, दैट्स इट। बट वी नीड टू go beyond that. There are many other professions which is actually limited to this caste only, these caste only, and which is actually not talked about the upper caste people or the privileged people. But हम लोग भी उनके बारे में नहीं सोच रहे क्योंकि हमारे लिए एक बहुत टनल बेस्ड अप्रोच है when it comes to the occupations of the scheduled caste. तो दिस इज जस्ट अ फूड फॉर थॉट। इसी वजह से मुझे ऐसा लगता है कि हम लोग को उन कास्ट के जो ऑल्टरनेटिव ऑक्यूपेशंस हैं, क्योंकि सीजनल ऑक्यूपेशंस पे भी हमने बिल्कुल ध्यान नहीं दिया यहाँ पे, जो कि हमें देना चाहिए। यूजुअली we always have this shortage of times, so this is also a food for thought कि बहुत सारी चीज ऑक्यूपेशन जो हमने लेफ्ट आउट कर दिए। और ह्यूमन राइट्स, मुझे ऐसा लगता है ह्यूमन राइट्स क्या है, कुछ नहीं है दलित्स के लिए। इट्स लाइक कि हम लोग जो कहते हैं ना कि दिस इज अ ह्यूमन राइट इशू, वो कहते हैं कि दिस इज अ सर्वाइवल इशू। तो जब तक हम उनके सर्वाइवल के ऊपर काम नहीं कर सकते, उन्हें अपने ह्यूमन राइट्स रियलाइज ही नहीं होंगे, क्योंकि उनका ह्यूमन राइट ये है कि उन्हें 2 वक्त की रोटी मिल जाए, सर्वाइव कर जाए। कोविड, जैसे मैंने स्टार्टिंग में इस पैनल के बोला था, उनके लिए कोविड एग्जिस्ट ही नहीं करता उनके मोहल्लों में कभी भी। और एंड आई एम टेलिंग यू दीस थिंग्स जो कि मैंने अपनी आंखों के सामने देखी या फिर मेरे को रिपोर्ट की गई हैं, कि उनके मोहल्लों में कभी मतलब टेस्टिंग टीम्स पहुंची ही नहीं। जो पहुंचना चाहिए थी उन्होंने घुसने नहीं दी, क्योंकि अगर वो घुस जाती तो उन्हें आइसोलेशन में भेज दिया जाता, और वो जो थोड़ा बहुत कमा रहे हैं वो भी नहीं कमा सकते, घर कैसे चलाएंगे? तो वी नीड टू अंडरस्टैंड एंड एक्सेप्ट द हार्ड रियलिटीज ऑफ ऑल दीज थिंग्स. So I'm opening the floor for all the speakers, for the attendees. Uh, we have they are there to answer your questions. आप पूछ सकते हैं, और the speakers are here.
We'll request all the speakers to switch on their videos for a minute or two. And yeah, please go ahead.
So Sylvia, आपके लिए एक सवाल आया था, and I guess you have responded to that, but I wanted you to speak also about the whole use of telemedicine thing when it comes to the caste, from the paradigm of caste.
Thank you. So basically, I had said that telemedicine is being promoted. It has been promoted even before the pandemic, and now the pandemic has given a reason for it to be promoted much more vigorously. And I have personally also done some telemedicine because there has been a need, and my main audience was the urban deprived areas, senior citizens who've not had access to doctors for the last so many months, and therefore, not taking any of their basic medicines for non-communicable diseases. And telemedicine is just not an option for those communities, because network is a problem, and it's very difficult for them to communicate across a gadget. And the idea of touch, the idea of examining a patient, I think all those are very important things. But it's the idea of telemedicine itself benefits only a certain class, and also I would say a caste group. It's people who are comfortable with gadgets and who have good internet connections, and people who they have the reports and they can send a WhatsApp image, screenshot, and keep messaging their doctors and go back and forth. It's a possibility with that very elite kind of group. And it's definitely not available to the more marginalized and vulnerable communities. So that is one thing. The other thing is also this idea of distancing oneself from patients. I think that comes from this whole caste and untouchability paradigm, because you want the benefits of being a doctor, you want to treat, you want to get the privileges, but then you don't actually want to examine a patient, you don't want to go near a patient, you don't want to touch a patient, because you don't know where they're coming from, you don't know what occupation they're doing, you don't know what caste or class background they are from. And therefore a lot of doctors and a lot of people who buy into this idea of distancing oneself, which I would call untouchability. They promote this idea of telemedicine. The other thing in terms of it as the amount of money that is invested into telemedicine and as a kind of a policy initiative, it's also a process of centralizing healthcare. So you have all these elite doctors sitting in big corporate hospitals in the city, and they do telemedicine. The doctors or the health workers at the peripheries are not trained. There's no investment beyond putting a telemedicine hub there. And all these doctors says this person looks jaundiced, or this person's x-ray looks suspicious, or they may be having a cancer, they may be having tuberculosis, send them to our hospital. So all patients under the so-called health insurance schemes, they all have to move towards a city for even basic treatments and basic healthcare facilities. And it's increasing the cost of care, and it is basically centralizing and commercializing healthcare. So the policy itself is anti certain communities. So that's what I meant.
Thank you, Sylvia, for this answer. Definitely, I agree to you that there's a lot of economic implication, and considering the fact रूरल एरियाज़ में जो यही लोअर कास्ट होती है उनके पास तो एक्सेस टू फ़ोन्स भी नहीं होता है, और टेलीमेडिसिन प्लेटफॉर्म्स ही नहीं होते हैं, और अगर वो भी होता है तो उनके पास एक्सेस ही नहीं होता है कि उन टेलीमेडिसिन प्लेटफॉर्म्स को कैसे रीच आउट किया जा सके. तो वो इम्प्लीमेंटेशन इश्यूज़ जो आते हैं, along with the cost issues and the cost effectiveness of that strategy is actually not at all thought when it is discussed. So I am definitely agreeing with you on this thought. The other question, this is for Kanika. Can you include nutrition support in your recommendations? This is from Mohan Rao.
Thank you. Yes, actually, nutrition support has been one of our important recommendations, and we recommend that there should be some facilitation for linkage with the nutrition schemes like Poshan Abhiyan, ICDS, especially for the female sanitation workers. So, yes, we've covered that in our detailed study report. Thanks for raising that.
So we will be waiting for all those findings to be in public domain.
Yes, actually, we have shared, I think Raman
Yeah.
has shared the link, but I'll share it again in the chat box.
Okay, and we can also share it over the email Jay said discuss also. Yeah. So I think so. Next question that I'm gonna ask is from Satyajit. There's a question from Krishna Swami Sankaran. It is more of a, I would say, way forward. Can we have a resolution for putting the cleaners and scavengers as priority for free COVID vaccination program? Adding to this question, it's like, what are the feasibility of this recommendation and resolution, how it can be done, and what could be the justified thing to put forth this kind of resolution? So this question is for you, Satyajit.
Let me point out that the question is really for the Swasthya Abhiyan. ये कोई एक के बस की बात नहीं है, ये अभियान के लिए सोचने की बात है कि क्या ऐसा प्रस्ताव हम पटल पर लें और उसको आगे ले जाएं। तो ये बात तो मैं जन स्वास्थ्य अभियान पे छोड़ रहा हूँ। एक बात लेकिन मैं कहना चाहूँगा, जो टेलीमेडिसिन को लेकर सिल्विया ने आपने बातें रखी, बिल्कुल जायज़ हैं, लेकिन मेरा मानना ये है, और मैं मेरे मुद्दे को जो चैट बॉक्स में बातें हो रही है उससे भी थोड़ा सा जोड़ रहा हूँ, कि हमें जनस्वास्थ्य व्यवस्थाओं का expansion चाहिए. We want that expansion not simply by providing a few more doctors and a few more hospitals, which I agree entirely with Sylvia, simply leads to greater and greater centralization without addressing the built-in inequities into that framework. What I would like to argue is that the pandemic, along with its crisis, is providing us an object lesson in the fact that community-based, decentralized public healthcare, integrated healthcare services, I apologize if I have given the impression to some of our colleagues that I meant that simply a response to the pandemic was at stake. I am simply using the pandemic as an object lesson for us to argue for a comprehensive, decentralized expansion of true public healthcare systems, which is where I am arguing that the creation of skilled, steady, dignified employment at all levels in the public healthcare system is an essential component of this demand, one which is both under extreme threat in the gig contract-based neoliberal version of capitalism. And I would argue that rather than simply saying that the current version of telemedicine being proposed is both incorrect and inadequate, I would like to argue that there should be a people's telemedicine that is integrated as a resource for frontline healthcare workers in a wide variety of ways that would empower both healthcare workers and the communities they serve. And I think that we in the Jan Swasthya Abhiyan need to think about how the technological resources implicit in the currently dominant idea of telemedicine can be reconfigured imaginatively in a true people's healthcare system as people's telemedicine.
Yeah, Satyajit, it was a very well put forth demand, and definitely I agree to you that it is not an individual's question to answer, and it is as a movement we should take it forth and decide our stake on that. And definitely during the whole this discussion, during this more than 1.5 hour, we have discussed that we all agree to that these individuals from coming from these castes are actually very much not receiving what they should be receiving because of their caste, and they are actually at a stage when this is very general thing for them, very normalized. This is their normal. So we need to definitely pin down as a movement ways to put forward these kind of things as for the government and other stakeholders, so that some actions could be taken. Apart from that, I would love to come back to Sylvia because I have read your report also. So Sylvia, you mentioned that there's a lot of differences when it comes to the care cases, removers, and the sanitary workers in the hospitals. How do you suggest that? What should be the point? Because we know that we all have very limited resources, and the current government is actually taking it very differently, and they whatever they are spending, though they are being a doctor, I would say they are also not spending on doctors, but as they are not they are target diverting most of the resources to the doctors and more privileged occupation, I would say. So what should be done कि safety maintain रह जाए इन लोअर कास्ट की उन्हीं occupations में, और कुछ ना कुछ किया जा सके. दूसरा मेरा सवाल था जो कि आपने अपनी रिपोर्ट में मेंशन भी किया हुआ है कि differences in the permanent positions of this population and the ad hoc positions. मैं चाहूँगा कि आप इस चीज़ पे भी थोड़ा सा लाइट डालें ताकि हम इस चीज़ को यहाँ पे डिस्कशन में रख सकें.
Thanks, Abhishek. I think the first thing that we should do is move away from this whole paradigm that the healthcare system equals doctors. This thing of placing doctors as next to gods and as somehow more important people in the healthcare system, I think that has to be broken. The healthcare system cannot function without nurses, and it cannot function without paramedical staff, the pharmacists, the lab technicians, the cleaners, the housekeeping staff. It's so the idea. I think with the HIV, the program, there was some discussion about that. There was a idea about integrated management of disease and the importance of all players, like even the patients, as equal stakeholders. I think that model is important for us to realize, especially in this pandemic, that doctors are not equal to the healthcare system. And therefore, what is important for each of those workers? And it's true what you're saying, that the housekeeping staff and the cleaners have been out on contract, and literally contracting is a very nice it's a fancy word. Actually, it's basically it's exploitative labor, which is again a reinforcement of age old traditional caste systems, where you want somebody, most of them are Dalit women who are coming in without any kind of protective mechanisms, whether it's in terms of the exposure to occupational hazards, to labor law violations, to their jobs being lost, to sexual harassment, to physical harassment. And I keep mentioning this harassment because it's something we don't realize the scale of it, the way the language that is used to some of these workers, by all people who function within the healthcare system. It's as though if you look at those within that tractor or that system as humans, then these people who work outside it are subhuman. So basically, you can speak down to them, you can abuse them, and as long as that model exists, I think it's going to be very difficult. And look at also it from a occupational hazards point of view. So I didn't elaborate too much earlier, but the kind of hazards that the frontline workers are exposed to, if you look at the diseases like hepatitis B or tuberculosis or HIV, they are more likely to be exposed to that. You also have cuts, injuries, needle injuries, with sharps, the kind of physical injuries that they get. There's also exposure to a lot of chemicals like, toxic chemicals which are used for cleaning and which are used for disinfecting. They're exposed to all of those things. Physically, it affects them. It also, through inhalation, it affects the respiratory systems. There's also the psychological occupational hazards in terms of like stress, working long hours, and apparently, from what the so-called policymakers say, the fact that these workers are working long hours is not even, in the list of things that one should be concerned about. But it should be foregrounded. And also in terms of so basically, if you look at exposure to these hazards, then the role of the vaccine is again very limited. Like, it's not only about a vaccine. It's not like, because as we know, the government, what they'll do is they'll say a scheme to vaccinate the frontline workers. They'll have a few media reports and they'll have a few photo shoots, and they'll say that's it, we've done our responsibility to the these workers. But I think, looking at it from a labor law perspective, looking at it from a caste perspective, looking at it from a healthcare system perspective, I think all of those are important. And those are the lessons we have to learn from the pandemic. We have to look at it from multiple angles and say that, say tomorrow there's another pandemic, then the vaccine is not going to solve the problem. The same problems are going to continue and they're going to be worse. So we have to look at how the system can prepare itself, learning from the lessons of this pandemic. And it can't be like a band-aid, or it can't be like a firefighting, or it can't be tokenism. It has to be a revamping of the entire healthcare system.
I totally agree to you, Sylvia, that this pandemic has actually made us realize, and I think so only us, not most of the people, that the difficulties that we are facing right now, it is just because of the weakening of the entire health system and the public health system that we have done previously in the last few years. And it is definitely is in a need. We have this pandemic now, we will be having epidemics and pandemics in future also. If we are not reviving the entire public health system, we are again gonna land up into the same situation, in compromising all the aspects of the health, human rights, and the well-being of everyone, including every other aspects of the life. So one thing that I would like to, the last question, it was not a question because I was not able to follow that chat. It was from Dr. Ananya Biswas. She is working in Bihar, and she she was discussing about the behavioral change that we need to install, because as per her observation, the frontline workers, especially the sanitary workers, are not much using mask. I might be wrong because I was not able to get that through that conversation properly. So is it feasible, and how this kind of behavioral change can be taken? Because there's also an issue that it is very difficult to change the behavior of the population when it comes to mask, especially this population and other parameters, for XYZ reason. So any of the panelists can answer that question. I guess Sylvia, you should go. And Satyajit, you can also.
Go ahead, Sylvia.
No, Satyajit, you can please go ahead. You started saying something.
I was simply going to say that when it comes to the deeply contested concept of behavioral engineering, I am very uncomfortable when it is targeted at disempowered sections of the community. I have absolutely no difficulty if we are discussing getting behavioral change in the great urban shopping malls. But when we begin to make structurally exploited, underprivileged groups in society the targets of behavioral change campaigns, I begin to have a whole range of socio-political worries. So I'm simply going to, all I was going to do was flag this and leave it there. This is not at all to say that it's not a problem if people don't do the communitarian things of wearing coverings across nose and mouth, of maintaining some level of physical distancing. Let me take the opportunity to press my months-long minor campaign that for that strategy to be called social distancing is just plain awful. The subcontinent has practiced social distancing in the form of a discriminatory and exploitative caste system for millennia. Really, we need to think about social distancing as that. What we need to think about is physical distancing and social solidarity. But that said, I think that it is important that these steps be adopted by everybody. I think it is important for the state to speak in a trustable voice and to put its money where its mouth is in order to persuade communities, especially underprivileged and exploited communities, that there is good intent in what is being said. But I am still extremely uncomfortable with a focused, targeted point about behavioral change amongst the poor and the underprivileged.
I totally agree with you, Satyajit. It is a very, very difficult question to answer because all through these years working in the field of HIV and sexual health, behavioral change is a very, very personal thing. I might have a different perspective, you might have a different perspective, and people takes into it the moralistic aspect of the behavioral change a lot and their personal biased opinions also. So definitely, I agree to your point. So there are two more questions, I would say.
Can I add a small point to that?
Yeah, sure, Sylvia.
Okay. So what I wanted to say is that I mean, I think there's a tendency with the government and also with policymakers to hold the community responsible for, you know, all the healthcare issues that are happening. And there's a tendency to say, like, if we've seen it in the context of nutrition and in the context of pregnancy related, you know, complications. And now also we're seeing with COVID that there's a tendency to put the onus on the communities to take care of their own health and blame them. And now there's a lot of policing that is happening. And even this whole thing of lockdown, containment zones, and you know, fining people for not wearing masks. It's this, in a way, the state absolving responsibility and saying you are not responding to the pandemic, and therefore we'll punish you for it. And that is pretty much the almost the whole role of the you know, governments as what we are seeing. And specifically in the context of the workers here that we're talking about, like I think the report, the link has been shared, and we've talked to the people. And if you see the kind of equipment that they've been given, it is so cumbersome. They've been given gumboots, and those gumboots are so heavy, and the workers ask us, how do you expect us to clear garbage wearing these gumboots? If you see those gloves, again, very bulky. Of course, a lot of them are working with bare hands. They've not even been given that. That's a different question. But when we are asked to give them protective equipment, this is the kind of completely impractical things that they're given. They're saying, you're asking us to wear a mask. The mortuary workers are saying, we cannot dig with these kind of masks because we cannot breathe. It's a lot of labor and it's difficult for us to breathe wearing these masks. So we have to take it off. But then the way that is translated is these workers are not responsible. These workers don't protect themselves. They are not bothered about their health. They don't care. It's as though they have a sense of fatalism, and it's, you know, entirely the burden of being injured or being getting occupational hazards from their occupation is entirely their fault. So this idea of ergonomics, like designing tools that are suited to the worker, is just not in existence. It's just tokenism. Even something as simple as gloves, you cannot ask someone to use gloves with the kind of garbage that they're handling and the kind of waste that they're handling. A needle prick injury is going to happen anyway. So I think the kind of resources of the country has never gone into looking at technology that is actually really protecting these workers. And I think that is a problem. It's not that, you know, the community is not doing enough to protect themselves.
Well, very well said, Sylvia. I would say hats off to you for this words because definitely अगर आपने उन्हें पहले चीज़ें दी ही नहीं थी, उन्हें उस चीज़ को यूज़ करने का एक्सपीरियंस ही नहीं है, एंड इट्स लाइक उन्हें अगर मैं इस चीज़ में एक चीज़ और ऐड करना चाहूँगा, अगर एडहॉक बेसिस पे हैं या फिर डेली वेजेस पे हैं, एक इंसान का जो काम कमंसरेट करता है उसकी वेजेस को, ठीक है, तो अगर वो फॉर एग्जांपल 2 कट्टा भर के रेजेस पिक करेगा तो उसे 10 रुपये मिलेंगे, उसी को अगर वो 4 कर देगा तो उसे 20 रुपये मिलेंगे, और अगर उसे आप ग्लव्स दोगे तो उस चीज़ को वो आधा भी नहीं कर पाएगा. Definitely, it's all about pennies that they are earning, and these kind of equipments actually slows them down. It is actually the way we have been and the way we have till now treated them. Again, जो कास्ट atrocities या फिर जो भी issues हम इस वेबिनार में हमने बातें की है, वो कहीं ना कहीं आज बनी हुई नहीं है, वो चीज़ें हैं जो कि बहुत पहले से बनी हुई आ रही थी, जिन्होंने इस टाइम भी अपना एक टोल लिया है और आज भी उस चीज़ों को और ज़्यादा डिटेरियोरेट कर रही हैं. तो हमें वो चीज़ डेफिनेटली याद करनी चाहिए. लास्ट क्वेश्चन मैं लेना चाहूँगा कि वी आर एक्चुअली रनिंग आउट ऑफ टाइम नाउ. इट्स लाइक इट asked by Mr. Jagdish Patel, we do not have any law to protect safety and health at work, either for municipal workers, including cleaners, or health workers. New OHS codes also do not provide any protection to these workers. How can we move forward demanding such a law? इसमें मैं एक क्वेश्चन और ऐड करना चाहूँगा कि जो हेल्थ केयर वर्कर्स हैं, उसमें भी अगर हम सैनिटरी वर्कर्स की बात करें या फिर इन जैसे अनसिक्योर्ड जॉब वाले लोगों को जो कि मतलब काम करते हैं क्लीनिंग में, स्वीपिंग में एज अ सैनिटरी पर्सन, बट उनको इस तरह के प्रोटेक्शंस नहीं है, तो हमें किस तरह की लॉ की डिमांड करनी चाहिए और उसका कहाँ तक फिजिबिलिटी है, और एज अ मूवमेंट हम लोग को किस तरह से प्रोसीड करना चाहिए. I just wanted it to be very short because we are actually out of time now.
Maybe Kanika can answer that.
Thanks. This is a very challenging question. I mean, the first step is that we need to acknowledge that sanitation workers are involved in different categories of sanitation work face as much risks as the health workers are facing, and we need to identify the kind of risks faced by different categories of sanitation work. So the workers in hospital settings face some kind of risks, and those in the those involved in cleaning of sewers and septic tanks face different set of risks, and the support systems available to them are different. So I think once we start acknowledging this and the different kinds of vulnerabilities they are facing, that can be the first step towards this. And in the study we did, we saw that some of the state governments and even some urban local bodies have put in place some guidelines specific to the COVID on ensuring the safety and health of sanitation workers, but we saw that not all categories of workers were being adequately covered in those, especially the informal workers. They were not finding a mention in any of those, and uh, the guidelines which we studied, they were covering some very basic aspects like provision of PPE, but how the personal protective equipment has to be used, how it has to be disposed or reused, and those nuances were not being covered. So I think we also need to look into these the technical details and the practicalities of it.
Yeah, thank you, Kanika. Just one liner from Satyajit and one line from Sylvia about the same question, and just one line or two line, not more than that.
No. On this one, I'm going to pass because Kanika said things and more than one, anything in the nature of a one-liner would be just too short.
Sylvia?
Yeah, I think Kanika covered it, so
Yeah.
I don't have anything to add.
Thanks a lot, everyone. Just few points. It's like we as GSA Delhi are trying what further steps, because we don't want it to be a discussion only, and we are looking forward to take all these points to work on this pandemic situation from the lens of caste also, and not only the caste and the issues related to manual scavengers, but I would say the whole range and spectrum of caste that is actually playing a significant role in deteriorating the health of a lot of people these timings. So we are happy and to get all those kind of suggestions from you all. You can definitely mail us also, and you can also tell us here, and all the points that we have discussed during this discussion also will be taken further, and let's see how we can move forward with this kind of suggestions. And we are also open for the continuous suggestion, and we are always available on the email also. With this note, I would also like to memorize Dr. Amit Sengupta. I still remember I met him in 2018 in Bangladesh, and a very inspiring person, I must say. He will definitely, वो हमेशा हमारे दिल में रहेंगे, और मुझे लगता है हम जैसे लोगों को और यंग लोगों को हमेशा और सबको इंस्पायर करते रहेंगे. I definitely commemorate him, and let us all keep him alive in our words and in our actions, especially in the ideologies and the things that he has taught to us. With this note, I would like to end this panel discussion, and we are soon going to start our JSA Delhi meeting. Those who wanted to join JSA Delhi general body meeting are free to stay back, and those who are not can leave the session. Thanks a lot.
Thank you.
Thank you.
Thank you so much to Sylvia, Kanika, Satyajit, and Abhishek also for excellent moderation.
Thank you.
Thank you very much. Namaste.
Ritik, can you make the announcement again?
या श्योर. सो जितने भी साथी जो दिल्ली हम लोग अब जेएसए दिल्ली के ऑर्गेनाइजेशन मीट में जाना चाहेंगे, जितने भी साथी हैं, चाहे वो दिल्ली के हों, दिल्ली के आसपास के हों, या फिर दिल्ली से बाहर से भी हों, अगर वो हमको ज्वाइन करना चाहते हैं तो हम रिक्वेस्ट करेंगे कि प्लीज़ हमारे साथ रुके रहें. कुछ देर और जुड़े रहें ताकि हम आगे का प्लान कर सकें आज के इस पैनल डिस्कशन के बाद और अन्य मुद्दों को लेकर भी। मैं चाहूंगी आई थिंक अभिषेक अगर कुछ नहीं कहना है तो ऑर्गेनाइजेशनल मीट के लिए हम इंद्रनील को चेयर बना सकते हैं। कॉमरेड इंद्रनील, अगर आप यहाँ से टेक ओवर कर सकें। गार्गे, कॉमरेड इंद्रनील शायद बोल नहीं पा रहे हैं, उनके
और दूसरा ये है कि मैं बात I'll make everyone the panelists so that there can be an internal discussion and people can see each other.
that will be great.
Yeah, because I think Kajal is also asking the same. I'll just take 2 minutes.
प्लीज। हाँ, तो साथियों, हम आप सबको क्योंकि ये अभी वेबिनार मोड में था इसलिए सबके पास बोलने का वो नहीं था, बटन उनका एक्टिवेटेड नहीं था, तो अब हम सेटिंग्स में चेंज करके सबको पैनलिस्ट्स बना रहे हैं ताकि सब एक ही वक्त पे कंट्रीब्यूट कर सकें एक दूसरे को सुनते हुए। तो थोड़ा सा वक्त लगेगा, 2 मिनट दीजिए, सबको पैनलिस्ट्स बनाया जा रहा है।
शुक्रिया ऋचा
जी प्लीज।
मैं रिक्वेस्ट करूंगा कि दीपा भी इस सत्र को मॉडरेट करे, हम लोग दोनों साथ में ये कर सकते हैं। दीपा आप अगर है तो प्लीज वेलकम।
हाँ इंद्रनील, मैं यहीं पे हूँ। थैंक यू। हाँ,
एक मैं छोटा चीज बताना चाहता हूँ। पिछला जो सत्र था आखिर में बेजवाड़ा जी ज्वाइन कर पाए थे, वो कहीं पर ट्रैवल करके इमरजेंसी में उनको जाना था बिहार, तो वो लास्ट में ज्वाइन कर पाए थे लेकिन तब तक खत्म हो गया था, हम लोग उनको जोड़ नहीं पाए। अगर आपको लगता है उनको जो इस डिस्कशन में हम लोग शामिल कर सकते हैं तो कभी हम लोग उनको बुला लेंगे, वो ज्वाइन करेंगे तो अच्छा ही रहेगा। हमारा जैसे दिल्ली के काम पे भी वो जुड़ सकते हैं। दीपा, ओवर टू यू।
हाँ इंद्रनील, हम इसे साथ में करेंगे, तो मैं शुरू कर देती हूँ। तो
हाँ।
सभी साथियों को सलाम, और जैसे दिल्ली के इस मीटिंग में आप सबका स्वागत है। सॉरी मैं अपना वीडियो ऑन नहीं कर रही हूँ क्योंकि मेरा काफी मतलब लाइन खराब रहता है, तो उम्मीद है कि आप मुझे सुन पा रहे हैं। मैं ये कहना चाहूंगी पहले तो जैसे दिल्ली की तरफ से, और खासकर जो इंद्रनील, ऋचा और ओसामा और दूसरे साथी जिन्होंने इससे पहले की पैनल अमित सेनगुप्ता के मेमोरी में जो पैनल आयोजित किया है, बहुत बहुत शुक्रिया, क्योंकि मुझे लगता है वो उस पैनल में जो बातें निकल के आई हैं बहुत जरूरी हैं, बहुत अहम है हमारे लिए भी। दिल्ली के स्तर पे जब हम इस मीटिंग के दौरान कुछ सोचें कि आगे कैसे बढ़ना है, हमें उन बातों को भी अपने ध्यान में रखना चाहिए। मैं ये कहना चाहूंगी, यहाँ पे मैं देख रही थी पहले तो पार्टिसिपेंट कौन है वो नहीं दिख रहे थे, पर अभी दिख रहे हैं, तो मुझे लगता है सभी जैसे से वाकिफ हैं, जानते हैं, परिचित हैं कि जैसे क्या है और जनस्वास्थ्य अभियान का क्या काम रहा है। तो मैं जैसे के बारे में कुछ नहीं कहना चाहूंगी। किसी का कोई सवाल है तो फिर हम उस पे बाद में आ सकते हैं, पर इस मीटिंग का मेन ऑब्जेक्टिव या उद्देश्य ये है कि जैसे दिल्ली के स्तर पे जन स्वास्थ्य अभियान पहले भी कई सालों से मतलब हम यहाँ पे पहल करते रहे हैं, पर पिछले कुछ सालों में काफी चुनौतीपूर्ण रहा है, और हम इसे लगातार या जितना हम करना चाहते हैं, जो पहल हम करना चाह रहे थे, वो जिस तरीके से हम करना चाह रहे थे हम नहीं कर पाए हैं। पर ये सही है कि जो दिल्ली जन स्वास्थ्य अभियान अपने मतलब कुछ हद तक और अलग अलग तरीकों से हम में से कई लोग जो जैसे नेशनल लेवल पे भी जुड़े हैं, दिल्ली के स्तर पे भी जुड़े हैं, हमने कोशिश की है अपने पर्सनल और दूसरे नेटवर्क्स के तहत या दूसरे ग्रुप्स के तहत कि कैसे जो स्वास्थ्य के जो मुद्दे हैं उस पे हम कैसे पहल करें, जो स्वास्थ्य के जो अधिकार जो हैं उसको कैसे हम आगे बढ़ाएं। और मुझे लगता है कि आज कई साल या दिन या महीने, पता नहीं, मुझे अभी याद नहीं आ रहा है, इसके बाद हम जैसे दिल्ली के तौर पे मिल रहे हैं और हम चाहते हैं कि इस मीटिंग के दौरान हम हमारी कुछ मतलब जो सुझाव हैं या हम कुछ टिप्पणी या कुछ आइडियाज जो हैं कि जैसे दिल्ली के सामने मतलब क्या पहल रहती हैं, हम जैसे दिल्ली को आगे मतलब किन किन मुद्दों पे या किन किन विषयों पे हमें ध्यान देना चाहिए, किन लेवल पे। हमेशा से जैसे दिल्ली जो है मतलब जमीनी स्तर पे ग्रास रूट ऑर्गेनाइजेशन के साथ और पॉलिसी लेवल पे भी हमने पहल की है, तो अभी भी वो चाहते हैं कि वो मतलब जारी रहे, पर जो उसकी छूट मतलब रही है, हम ऑर्गेनाइजेशन के साथ इतनी लगातार नहीं जुड़ पाए हैं, तो हम चाहते हैं कि आप सब अपनी बातें, अपनी जो मतलब कुछ सजेशंस रहेंगे या कुछ पॉइंट्स हैं या जो भी है वो आप रखें ताकि इस बातचीत को हम आगे ले जा सकते हैं। कुछ पिछले कुछ महीनों में या कुछ हफ्तों में जैसे दिल्ली के जो करंट कोऑर्डिनेटर्स हैं, इंद्रनील, ओसामा, रिचा, शायद मैं किसी और को भूल रही हूँ, सॉरी, पर मेनली जहाँ तक मुझे पता है इन तीनों ने इसको मतलब लाइव रखा है और उनसे भी सुन सकते हैं कि जैसे दिल्ली की तरफ से इन महीनों में खासकर कोविड और मतलब लॉकडाउन के समय क्या कुछ पहल जैसे दिल्ली के तरफ से हम कर पाए हैं और उससे निकल के जो मुद्दे आ रहे हैं उसको हम आगे कैसे ले जा सकते हैं। पर पहले मैं चाहती हूँ कि यहाँ पे जो जुड़े हुए हैं साथी कि वो बताए या वो कुछ अपनी बातें रखे कि जैसे दिल्ली कैसे मतलब किन मुद्दों पे हमें फोकस करना चाहिए जो बहुत जरूरी है दिल्ली के स्तर पे आज, और कैसे हम इसको कर पाएंगे। तो द फ्लोर इज ओपन। इंद्रनील, इफ यू वांट टू ऐड एनीथिंग टू दिस।
नहीं, थैंक्स दीपा। मेरे ख्याल से बाकी साथियों का सुनते हैं, उनका उपलब्धि क्या रहा और सुझाव के बारे में भी आ सकते हैं, और फिर हम लोग कुछ जो एक्टिविटीज हम लोग कर पाए थे उस पे हम लोग बताएंगे, थोड़ा सा शेयर करेंगे। लेकिन पहले सब साथियों का सुनते हैं कि कैसे खास करके दो चीजों पे कि जो पिछला कुछ समय का रहा है और दूसरी बात कि आगे जैसे दिल्ली को अगर एक कैसे अपना हमारा जो प्रोग्राम्स है वो कैसे हम लोग और दुरुस्त करें और जो स्वास्थ्य का अधिकार है उसको एक राइट के तहत दिल्ली में अगर देखना है तो आगे कैसे काम करें, उसके बारे में सुझाव बहुत ज्यादा जरूरी होगा।
जो कुछ बोलना चाहेंगे, मेरा सजेशन है कि आप वो जो या अपना माइक अनम्यूट करके बोल सकते हैं या आप अपने मतलब हाथ उठा सकते हैं। यहाँ पे मुझे दिख नहीं रहा है पर शायद वो, हाँ, रेज हैंड वाला जो ऑप्शन है तो वो आप यूज कर सकते हैं ताकि बारी बारी से हम सब अपना सुझाव यहाँ पे साझा कर सकते हैं।
Ma'am, may I add something to this?
Please.
फर्स्ट ऑफ ऑल मैं जन स्वास्थ्य आंदोलन के साथ फर्स्ट टाइम ही मैं मीटिंग में बैठा हूँ और मेरे एक कॉलीग हैं जो इस मीटिंग को मॉडरेट कर रहे हैं, उन्होंने ही मुझे इस लिंक को शेयर किया था और मैं जो जैसा कि अभी मैडम ने बताया कि हम कैसे आगे जो इसके ऑब्जेक्टिव्स हैं जन स्वास्थ्य आंदोलन के, उसमें हम कैसे उसको वे फॉरवर्ड ले सकते हैं। इसके
आपका परिचय थोड़ा बता देंगे?
यस, तो मैं एम्स जोधपुर से मास्टर्स इन पब्लिक हेल्थ हूँ। मेरा नाम डॉक्टर दीपक है। मैं BDS बाय ट्रेनिंग हूँ एंड मैं करंटली फेलोशिप कर रहा हूँ मिनिस्ट्री ऑफ हेल्थ एंड फैमिली वेलफेयर के साथ। और जो मैडम ने जैसे कहा कि हम कैसे इसको वे फॉरवर्ड ले सकते हैं, इसमें मैं सिर्फ 2 पॉइंट्स को मैं ऐड करना चाहूँगा। जैसे कि एक सीनियर प्रवक्ता जो अभी थे, उन्होंने कहा कि आप सिर्फ बोल रहे हैं, क्या कोई सबूत भी है क्या? तो उसके रिगार्डिंग में मैं जस्ट इतना कहना चाहूँगा कि जितने भी NFHS या फिर और भी जो गवर्नमेंट ऑफ इंडिया के जो डॉक्यूमेंट्स रिलीज होते रहे हैं, उसमें ये चीज़ देखी गई है कि फॉर एग्जांपल इम्यूनाइजेशन कवरेज की अगर मैं बात करूं, तो जनरल पॉपुलेशन में अगर 70% है, तो SC और ST पॉपुलेशन में 50-40